Welcome back, everybody. We're going to talk here about metabolic acidosis. Now, this is very commonly tested on your exam because you can use a lot of those labs, and it does harken back a little bit to your physiology and biochemistry. And so it's going to be really important that you understand how to distinguish the different acid-base disorders at a laboratory level, and then also know how to apply that to clinical management. Okay, so I am going to go into both some of the basic science, and then we'll kind of move into the workup and management of these various causes of metabolic acidosis. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. And definitely subscribe to my channel and you will get notifications every time I put a new video up. Okay, so you can kind of conceptualize the metabolic disturbances, and really you can also call this acid-base imbalances or disturbances like this. Okay, you got acidosis or alkalosis. The normal range of blood pH is 7.35 to 7.45, so a very narrow range. And because of the very complex buffering system in our blood, we can keep our blood pH very narrowly regulated, and that's really, really important. So if we are lower than 7.35, then we consider it an acidosis. At that point, then you need to determine whether you're dealing with a metabolic acidosis or a respiratory acidosis, and that's based on which parameter is abnormal. We look at the concentration of bicarb, which we would get on a BMP, and we look for the partial pressure of carbon dioxide, which we would get on an arterial blood gas. So both the ABG and the BMP or CMP are of the utmost importance in determining which kind of metabolic disturbance you're dealing with, and that's going to be important for formulating your differential diagnosis. Now, with metabolic acidosis, we can also distinguish this in two flavors. The anion gap metabolic acidoses, which is going to be the primary focus of our talk here, and the non-anion gap metabolic acidoses, which are a little bit less complex. There's fewer causes. We're going to be focusing right here. All right, so this is kind of what I already talked about. So metabolic acidosis is a low pH along with a low bicarb. Okay, bicarb is the marker of metabolic acidosis or alkalosis if it were high for whatever reason. The clinical syndrome is very nonspecific. So nausea, vomiting, chest pain, tachycardia, tachypnea, and that tachypnea often comes in the form of something called Kussmaul respirations. And Kussmaul respirations is very rapid, deep breaths. So think if you go and you're not in really good shape, you go run 500 meters, that's kind of a Kussmaul respiration, okay? You're breathing very deeply and very rapidly, and it's kind of the same idea. As you exercise, your blood pH does drop, and so you go into that sort of Kussmaul respiration. Now, you can have some other symptoms that are more specific to the cause, and it's going to be really important that you're familiar with those. Now, the initial treatment is always stabilization. So I'm going to go into some various treatments here of the different causes. Those are specific treatments, but no matter what, if a patient comes in with a clinical syndrome that looks like metabolic acidosis, and really if a patient comes in with anything, you've got to stabilize them first. So a lot of these patients are going to be volume depleted, particularly as we talk about diabetic ketoacidosis, for instance. So it's very important that, number one, we stabilize them by giving them fluids. Okay, so don't lose track of that. The most important labs are BMP and ABG. This is absolutely critical to determine that you're dealing with a metabolic acidosis or any other kind of acid-base imbalance. The BMP will give you your bicarb, the ABGs will give you your PCO2. Urinalysis is useful as well. Fingerstick glucose, this is so important, guys, so important, because one of the most common causes of metabolic acidosis is DKA, and these patients will be extremely hyperglycemic. If you have a patient who's obtunded, altered mental status, non-responsive, and you get a fingerstick glucose and their glucose is like 450, you're dealing with DKA. Okay, very easy. to diagnose, and you can start treatment right away. And as you know, with DKA, starting treatment immediately is of the utmost importance. And then further workup is based on the history and presentation, things like a toxicology screen, which will measure the salicylates, serum methanol, ethylene glycol, and so forth. This is how you diagnose an acid-base disturbance. So I'm not going to go through all of these individually, but this is sort of my approach. So when you get your ABGs, you'll know if your blood pH is disturbed. If it's not, if it's between 7.35 and 7.45, you're either dealing with no acid-base disturbance or a compensated acid-base disturbance. And at that point, then you look at your bicarb and your PCO2. That'll tell you whether you're dealing with metabolic or respiratory. And of course, one of those need to be abnormal. Bicarb is a marker for metabolism, whereas PCO2 is a marker of respiration, and this will help you determine. In the case of metabolic acidosis, then your next step is to check the anion gap, and I'll go into that in the next slide. Now, you can have compensated acidosis or alkalosis, and basically the way that this happens is, let's say that your bicarb is low, so you have a low pH and a low bicarb. Well, how would you compensate for that? You would compensate for that by breathing out CO2. Remember, CO2 will make you more acidic. So by breathing out CO2, you push it in the alkalotic direction. So if you have a reduced PCO2, then you know that you have some respiratory compensation. And it works vice versa and vice versa with respiratory acidosis and alkalosis. You have the other parameter going the opposite direction. That is indicative of compensation, which of course is a good thing. Then mixed means they're both going in the same direction. And I don't mean direction up and down. I mean they're both going the acidosis direction or the alkalosis direction. This is the anion gap equation. So what we're doing is we're taking our cations and subtracting our anions. Now, normally the range for an anion gap is less than 14. That is normal. Some say 13, 14, basically the same. So why do we have an anion gap? Well, it just so happens that we're not measuring all the actual anions in the blood. We're measuring sodium, potassium, chloride, and bicarb. And there are some anions in the serum that are not being measured. And so when we do this equation, we will have more measured cations than anions. Now, this is going to be really important because in the blood, you have an equal amount. So you have equal cations to anions. Now, when you measure, let's say you have excess anions from some sort of organic acid, then you're going to have more unmeasured anions. And so this number is going to be higher, and that is where we get the anion gap metabolic acidosis. And I'll go into that a little bit more when we get to some of these. We'll talk about methanol toxicity. Winter's formula tells us if we are correcting. So your expected PCO2, if you have a metabolic acidosis, so in other words, a low bicarb, is by this formula. So you take the concentration of bicarb, multiply it by 1.5, add 8, and then the range is that number plus or minus 2. Okay? So you should know this formula. Okay, the non-anion gap metabolic acidoses include the RTAs, diarrhea, and the use of lithium. Those are the big ones. The anion gap metabolic acidoses we're going to go into here. This is the very famous mud piles mnemonic. So we'll go into each of these. The one that I'm not going to talk about, however, is isoniazid toxicity. As you probably know, isoniazid is one of the more common drugs that we give for tuberculosis infection. Okay, so methanol toxicity. This is caused by ingestion of methanol. Isn't that a surprise? This is found in perfumes and colognes. You can find it in windshield washer fluid and then in domestically produced alcohol like moonshine. And this can actually absorb transdermally, but usually when this presents in the hospital, it's going to be because of ingestion. Symptoms here are pretty characteristic. So what you have here is, yes, altered mental status, metabolic acidosis. That's not really a symptom, it's a laboratory finding. But the big one that gives this away is the visual disturbance. This is really the only one that will cause the visual disturbance. So look for decreased visual acuity and photophobia in conjunction with features related to acidemia. Those are going to give it away, the visual symptoms with methanol toxicity. So on physical exam, you may see a decreased pupillary reaction to light. You may see optic disc hyperemia. The metabolites of methanol are neurotoxic, particularly to the optic nerve. Remember, the optic nerve will conduct light. It's responsible for the light reflex, and it also conducts the vision, so you can get visual disturbances. The diagnosis is really based on the clinical exam and the history. Because the treatment for this is so benign, we keep a very, very, very low threshold for diagnosis. However, the most accurate test is indeed a serum methanol level. Now, how do we treat this? Well, in the hospital, we give fomepizole, and fomepizole will prevent or slow down the metabolism of methanol. Methanol itself is not toxic. It's the metabolite, the formic acid that methanol is broken down into that is toxic. Okay, so this is the pathway. Notice alcohol dehydrogenase, the same enzyme we use to break down drinking alcohol, ethanol, is responsible for breaking down methanol. So what do? We give fomepizole, or you can give ethanol. So you got a mom whose baby just got into, or little kid just got into, drank her perfume or something like that. And let's say she's 2 hours away from an ER. What are we going to tell her? Literally, I'm not joking. Give your kid vodka. Okay, what it's going to do is it's going to it's going to inhibit the alcohol dehydrogenase. It's going to compete with the methanol. And so you'll have less conversion of methanol to this very toxic formic acid. Formic acid looks like this. Okay, here comes back your OChem. Okay, so that's formic acid. It will donate a proton to water or to whatever, and then you wind up with this, formate, okay, and acid. So this formate here, oh, I'm sorry, I didn't draw this right. That should be a negative. Okay, so this is formate, and this is an anion, and this will not be measured in your BMP. And so you'll have this extra anion that's not measured. Consequently, you're going to have an anion gap. Uremia, I'm not going to go into too much. I have a video on chronic kidney disease. Basically, what happens here is that you have these excess acids that particularly include uric acid or urate, but there are other acids that are involved when you have significant renal failure. This will collect, they'll donate protons, basically the same idea here. The treatment, if you're dealing with someone with stage 5 CKD, you're going to do dialysis. If they have less severe, let's say stage 3 or stage 4, you can try giving them sodium bicarbonate and see if they respond to that. DKA, probably the number one cause. DKA is caused by a deficiency of insulin, so we tend to see this in type 1 diabetics. And what's happening here is that they are unable to get sugar into their cells. Their cells perceive them as starving. They start breaking down fats. One of the products of fat metabolism is ketone bodies. Ketone bodies, like beta-hydroxybutyrate, those are weak acids. They will donate protons. They will then exist as anions, causing the anion gap. Now, the ketone bodies themselves can spill out into the urine, and so on urinalysis, you'll see positive ketones. They can also spill out into the saliva, and you'll get that characteristic fruity odor to the breath. Classically, this presents in somebody who's not responsible for taking their insulin. Okay, so a little kid, maybe whose parents aren't doing a very good job of parenting, teenagers, young adults, maybe they're rationing their insulin. Sadly, they can't afford it, or maybe they're just not being responsible. It happens. Symptoms, your typical metabolic acidosis signs, and then polydipsia, polyuria, polyphagia. Why does this happen? Well, polyphagia, because their cells perceive them in a state of starvation because there's no glucose getting into the cells. It's all sticking around in the blood. Polyuria. Why? Glucose spills out into the nephron. It pulls water with it. It dehydrates them. The average DKA patient is 6 liters deprived of water, of fluid. So they are very, very, very hypovolemic in most cases. And then polydipsia, same idea. They're dehydrated. So we talked about what you'd see on physical exam. These patients tend to be thin. They'll be dehydrated. And then that sweet-smelling, fruity odor to their breath. Okay, so on labs, you may see a hyperkalemia. Why? Because insulin pulls potassium into the cells. If you don't have a lot of insulin circulating around, the potassium is going to stick around in the bloodstream and cause a hyperkalemia. Now, this can be severe enough to cause EKG manifestations and cardiac arrhythmias. But you have to keep in mind that these patients, because of the polyuria, they are actually potassium deficient. It's just they're potassium deficient in their cells, not in their bloodstream. So we have to be careful because when we give these patients insulin, it's going to rapidly pull potassium out of their blood and it can very quickly precipitate a hypokalemia. Urinalysis will show positive ketones. That's not the only place you'll see positive ketones. You can also see it in a starvation ketoacidosis. One of my favorite tricks to do with patients is if they have a urinalysis and they come back lightly positive for ketones, I can go in and tell them, you need to eat more, because that's one of the first things that'll happen if you go 12, 14 hours without eating. Okay, so it's just an indicator of fat metabolism. The treatment here, I'm not going to go into the details of DKA treatment because I have a whole video on that, but it's very important to make sure you correct the fluid loss. Like I said, these patients are very fluid deprived because of the polyuria. Check the electrolytes frequently, at least every 2 hours. I go with every 1 hour because these patients can very quickly become hypokalemic once you give them insulin. If their potassium drops below 3.3, you have to stop the insulin and you'll give them supplemental potassium. Once you get back above 3.3, you can start the insulin again. But hyper or hypokalemia, any kind of disturbance of the potassium, is one of the most common complications of DKA. And then you also want to treat for underlying infections. So do pan cultures, get a urine culture, get a chest x-ray looking for pneumonia. If they've got consistent symptoms, get a lumbar puncture with culture and cytology, and so on and so forth. Blood culture is good too. Okay, this is an algorithm for you. Propylene glycol toxicity, not very common, so I'm not going to go into this in too great of detail, but rarely this can occur in people who are getting frequent infusions of benzos or barbiturates. So one of the populations I would think could be at most risk for this is alcoholics who are in the hospital with delirium tremens. We're giving them a lot of benzodiazepines. In the IV formulation of benzodiazepines is propylene glycol. So if they get enough, theoretically, they can get propylene glycol toxicity, but this is not common. Isopropyl alcohol toxicity. Isopropyl alcohol is rubbing alcohol. So this is another thing that you can get in ingestion, a poisoning in a little kid. It's not very tasty. I mean, I've never tasted it myself, but I've smelt it. So it's not one of those things you're probably going to see too often, maybe more in suicide attempts. One of the things that stands out here is that isopropyl alcohol is very, very irritating on the gastric mucosa. It can cause bleeding, and so hematemesis is a salient feature here, and so you have to keep that in mind because this will separate it. But otherwise, you're going to have very similar symptoms. The treatment is supportive observation. I would admit these patients, observe them overnight, give these patients a PPI. Now, the literature I have read says give a PPI if there's upper GI bleeding. Personally, proton pump inhibitors are very non-toxic. They're very safe drugs. Just give it prophylactically. This is the osmolar gap equation, and you can see here the calculated osmolality. This isn't super high yield for your exam, but it doesn't hurt to know this. Lactic acidosis has a lot of causes. The big one is shock. The reason is because shock causes lack of tissue perfusion, which will send the cells into an anaerobic metabolism. Lactate is a product of that. Lactate is, of course, a weak acid, and basically the same thing happens here. Another cause, metformin toxicity. Why is that so common? Well, because we give pretty much every stinking patient with type 2 diabetes metformin. It's very effective, but in some patients, it can cause lactic acidosis, so we have to keep an eye out for that. Symptoms are going to be consistent with the underlying cause. If there's shock, you're going to know it. Sepsis, cardiogenic shock, hypovolemic shock, just keep an eye out and treat the underlying cause. You will not see ketones in the urine here because this is not caused from a ketone. Lactic acid is not a ketone. The big thing here, because shock is often the underlying cause, maintain volume. If you fluid replenish these patients, it will increase the blood pressure, they'll get better perfusion, they'll go out of anaerobic metabolism, and the lactic acid will drop. Ethylene glycol toxicity. Where do we see ethylene glycol? Antifreeze. Antifreeze, I don't know if you've ever seen it. It's often blue or purple or green. It looks like juice or Kool-Aid. Kids get into it. It's also sweet. Ethylene glycol has a sweet flavor to it. So this is a very, very, very problematic cause of accidental poisoning. And you can see an adult with suicide attempt. This is not the way I would want to go out if I wanted to. Now, ethylene glycol will be converted similar to methanol by those enzymes, but it will form oxalic acid or oxalate, and this is what causes the acidemia. Now, oxalate will get into the nephron, and it will pair up with calcium, and it'll form calcium oxalate. That is a solid. So now you're going to have a stone, and this is what causes those envelope-shaped or dumbbell-shaped crystals. And so that's kind of a giveaway. Now, because calcium gets hogged up by the oxalate, your calcium is not going to be reabsorbed, and that can give you a hypocalcemia. Most accurate test is an ethylene glycol level, but this is often very easy to diagnose based on the history. Same treatment as for methanol toxicity. What we want to do is we want to hog up that ADH, that alcohol dehydrogenase, so that we have less conversion of ethylene glycol ultimately to oxalic acid, which would cause the nephrotoxicity. These are the calcium oxalate crystals. Salicylate toxicity is caused by an overdose of a salicylate. Most commonly, that's going to be aspirin. However, you can also find salicylate in other things like wintergreen oil, which is going to be found in things like Bengay or the tiger balm, as well as bismuth salicylate, which can be found in Pepto-Bismol. So you can get toxicity from that as well. Again here, look for accidental overdose. You can get signs and symptoms of metabolic acidosis, but the big one that separates this apart is tinnitus because it is neurotoxic. So look for that. Ultimately, these patients can have seizures too. Diagnosis here, again, you're going to have this metabolic acidosis picture. When it's associated with a history of aspirin consumption or they have tinnitus, this is the presumptive diagnosis. Most accurate test is a plasma salicylate level. This is actually going to be on a routine tox screen, so you don't need to order any extra tests here. The treatment is gastric lavage. I would also add activated charcoal. So doing both is more effective than doing one or the other alone. If they have severe symptoms, you may alkalinize the urine. That's going to promote excretion of the metabolites. And then you want to start IV fluids as well. And then this is just everything we went over. So here's the classic patient type you may see it in, some of the salient features or peculiarities to differentiate them, and then the best way to diagnose and the best way to treat, bearing in mind that in most cases, we are going to treat these patients presumptively based on the history.